is my daughter, and my question is, we've encountered rhabdo for the first time 2 years ago. I don't know how we missed 18 years of it, and listening to all of we understand about exercise and movement and all of those things in sick days. With rhabdo, what is really a good recommendation for movement versus not? Because it seems like all or nothing, and we don't seem to find much in between as we can't escape this particular series. So I was curious what your recommendations would actually be. I'm good.
I think that's a really hard, I think when we talked earlier, it's really individual. So it's going to be really hard to say where's your tipping point on that tightrope. It could be 10 minutes, like you need to start really, really slow. I don't know. Alex?
So I would agree. It does, as you know from when we work together, it takes experimentation and seeing what's tolerated, where is that line.
Video family.
I would say go little by little. It may seem like, okay, I'm only changing a minute or I'm only changing the intensity a slight level, but that's the pace I would say to go at, just to see what is tolerated versus what isn't.
Hi, I'm Michelle, mom to Jake. He's 20, he has LCHAT. And mostly a question for Melanie is, just curious what your recommendation is for a sick day formula. It seems like everyone's is a little bit different.
That's a great question, and I would agree, everything's a little bit different. So I guess I don't have a specific formula I would recommend, but just knowing that a fever raises your energy needs by about 11%, and if you're not eating, if your energy needs are going up and you're eating less, then trying to get those calories in. So I think it kind of is what works for your child and young adult as far as increasing the calories when they're sick. So it's really kind of balancing that increased demand with often feeling like you don't want to eat because you don't feel good. So.
Anyone else? Question for our panel?
Enerji ihtiyacı olduğu zaman enerji açısından karbonhidrat mı, protein mi, yoksa şekerle mi karşılamak gerekiyor?
Question is more energy. How are we going to cover that with the C7, MCT, or carbohydrates, or basic foods, or protein?
Oh, during sick days.
Yes.
During sick days.
Thank you.
Gotcha. So during sick days, I would probably focus on the carbs in the C7 or the MCT. Maybe a little bit more protein, but I'd probably focus on those two nutrients rather than increasing the total diet. So carbs and a little bit more MCT or C7. Yeah.
Anyone else? Questions? Okay, so I'll go with some of the questions we have here from our virtual folks. I understand why exercise can trigger metabolic crisis, but can you explain why excitement can't?
I can give you an educated guess. I don't know that we've ever done any really good studies, but I do think that so excitement, adrenaline, other hormones can certainly increase your energy expenditure. Stress certainly increases your energy expenditure. So I think all of those things play a role in that balance equation. Now we've never studied that, like I've never measured cortisol levels. Do you know of any papers that measured cortisol? Or?
No.
So I don't know that we've actually physically measured it, like in a low stress and high stress situation. So that again, that's a bit of an educated guess, but based on what we know on stress hormones and what that does to your energy balance, that would be my thought.
I think that makes sense.
Okay. Next question is, I'm a patient on C7 oil. I often make myself a mixture of fat-free milk, carnation breakfast, and C7. I put it in a thermos and I'm ready for the day. Can I make this ahead of time and store it in the refrigerator, or will this adversely affect the oil because it will be in an environment lower than 38 degrees Fahrenheit?
I'm so excited I get to answer that question. Because I just, Amy's in the back of the room, right? We just had a poster at Surge, and so the Ultragenics folks did a really nice job of looking at this, and they measured the stability of mixing it in a formula and setting it at room temperature for 4 hours, and then keeping it in the fridge up to 48 hours, and the C7 was stable. You had to shake it, it would fall out of solution after a while. But it was stable and measured 100% recovery after that time. So the answer is, yes, you can make it ahead of time, put it in the thermos, and you're good to go for the day.
Wonderful, thank you. Next question is, how long after an episode of rhabdo should you refrain from exercising?
So unfortunately, there is not a lot of research into this area, so I don't have a definitive evidence-based answer for you. But I will say, after rhabdo, once your symptoms seem to have subsided and you're tolerating daily activities fairly well, I would start with light stretching and see how that goes. And if that goes pretty well, maybe try really low, maybe 5 minutes of activity. This isn't an instance where you want to jump into HIIT exercises. This is where you might want to try a light walk if you tolerate that well. If you like the water, you can try moving around in the water for a little bit if you have someone around to make sure it stays safe. And then continue on from there. Just gradual progression is key.
Any of our other panelists have thoughts about that? That's it, good answer? Okay, we're sticking with it. Okay, next question. I'm a patient with a lot of fatigue in the morning. Can you give suggestions on how I can minimize this? And why do you think FAODs have so much fatigue in the morning time?
I'd just be guessing, but it's possible you sleep all night, you haven't eaten anything, and it would just be fatigue from declining energy reserves, I would think. So maybe a glucose breakfast?
Yeah. Again, that's an area where I'd love to have more research, but I don't think we know a lot about why there's more fatigue at certain times. And I think it's probably different for everybody, so not every patient's going to describe the morning fatigue, although I have a lot of people that do. And then how do you minimize that? Well, I think, again, I would experiment with a couple different options, whether that's different types of breakfasts that help you minimize that in the morning, or even trying adding right before you go to bed snacks, see if you feel better the next day.
Okay, great, thank you for that. Yeah.
This is distantly related, but I have had patients who have had brain injuries or strokes where they are no longer in the hospital, they're at home, but they will tell me that they wake up and they're just really tired, that their sleep schedule is usually shifted slightly, where they're going to bed a little earlier and therefore they're having dinner a little earlier, and they wake up and aren't feeling so great. And some things that have helped them out has been intermittent snacking throughout the day, so just to further collaborate with what they were saying, maybe changing the timing on meals or snacks.
I have a follow-up question to that in regards to the morning fatigue. So Keenan, he always has what you could consider maybe morning fatigue. I guess the question is, how do you know that it's not just 6-year-old wanting to get 30 more minutes of sleep and he hates school and I don't want to get up right now and I don't want to eat oatmeal, how do you know it's not that and it's actually, this is VO-CAT? And I guess that's my question for an umbrella of things. Is it VO-CAT or is it him and he's 6? And there's some things where there are clear markers and some things where there's not. And I guess when to take it, are there things I should be on the lookout for to know, okay, wait, yeah, no, this isn't, you just don't want to school. We need to stop and do something. We do the overnight, and we do the snack right before bed, like right as he's closing off his eyes. We're like, okay, open your mouth, open wide, you know. So we do that. We don't do the middle of the night feed anymore as of a couple years ago, but is that something we should look more, you know, just I'm wondering how to differentiate it. Is it that, or is he's 6 and he just wants a couple more minutes of sleep?
So, Sharika, I think you know him better than the rest of us do, and I don't know that any of us can answer that. I think that's something that you're just gonna, I mean, it's gonna kind of depend. It's just an added layer to parenting that you're gonna deal with. I don't know that I could answer.
I just wanted to add to that last question about morning fatigue. What's helped our kids is with our dietitian is a bedtime snack with protein is really important because it helps them stretch out, and even fiber, like some high fiber fruit that helps them stretch those calories out through the night.
So I would say bedtime snacks, I'm a big fan of some protein, some fiber, and some good nutrition. So the fruit has other micronutrients in it too. So all of those kinds of things I think are helpful. And it does help kind of maintain that blood glucose a little bit more stable throughout the night.
This kind of goes back to what you were talking about, rhabdo, and I was just curious, like as a physical therapist, like your recommendations for after rhabdo, whether or not you feel like it's helpful to try to get to physical therapy with our kids, so we know how to like navigate that. Like, would that be? I know it's not something that's always recommended right now from our clinicians, but some kids have done that, and then like what would be maybe the benefits of that, or what could be the potential pitfalls of that?
My feeling is it's always nice to just have someone else take a look and see how things are. The big things that I look for when I do a new patient evaluation is there any change in their functional mobility? Like maybe they are going through rhabdo and they're kind of looking the same, but how they're standing, the quality of it is different. So that might be a sign to me like, okay, maybe we need to dive into this a little and strengthen certain muscles so that they can be more safe and independent.
You would recommend
I would recommend
physical therapy.
at least getting the evaluation, and PTs are usually really good at telling you, you know, I know this happened, but everything I think is going to be fine. You try these things at home, and if anything changes, you're always welcome back. Or saying, you know, maybe just a little tune-up of physical therapy is a good idea.
So do you think it would be helpful then to take a child into PT before they end up in rhabdo? Like if we know like it's going to happen at some point, like so you have like a connection so they can see how they are before their episode, so they have a comparison?
That can definitely be helpful. I will say there is not a lot of physical therapy research out there regarding these disorders. To my knowledge, I have a case study that's in line to be published in the Journal of Pediatric PT that I believe is the first one. I'm hoping to do more research in the area, but the typical PT might not necessarily know about these disorders, so you might have to do some education with them. But if you tell them certain things like, they stood at this age, they started walking at this age, this is what they're doing in school, and this is what I'm concerned about in gym class, in recess, in recreational activities, whatever it might be, they can do some standardized testing that can just see how they're lining up compared to their age and sex-matched peers to see if everything's looking good, they're on track, or if maybe some PT is indicated, or occupational therapy.
Any other questions?
I was not in here, so I don't know what we're actually talking about, but I had a question about one of my children, or both of them, I'm not sure, want to take a cooking class, and I'm all for it because I think it's a great skill for them, but I'm not sure to what extent I should prep the school that I'm looking at, because I don't know if they should learn just to cook before we add in the complexity of cooking low fat, I don't know what's more important. And if anybody had any opinions.
Has anybody gone?
When my daughter was in high school, she was really interested in doing the culinary program at the tech center because she wanted to learn how to cook. So she had a 504 set up with all of her dietary restrictions and things like that. So we went into the class. We had an opportunity, like an orientation night, where we get to meet the chef and who was teaching the class and everything. So what we did was go over what her restrictions were, because there's a lot of, when you're cooking things, there's a lot of trying things out. And so we wanted to make sure that they knew these are the things that she could have and these are the things that she can't. But you know, she went through the process of learning how to cook everything. And then when it came to the tasting, then we just made sure, because she was on the Try Have to Know and trial, that she didn't have anything with coconut in it, and that she didn't have any of the high-fat stuff, and they were really accommodating with that.
Thank you.
For muscle weakness and myopathy, is anyone measuring it in any way so that you can track progress or regression?
In physical therapy, we do manual muscle tests, so that can be kind of like you've probably seen it done in the hospital. The physician might have the patient like lift their leg up and try to push it down. That's a quick screen. In PT, we get a little more technical and we'll use a handheld dynamometer to more formally measure muscle strength over time.
So we're conducting a natural history of L-child retinopathy study, but in that study we're also following the neurological assessments really closely as well, because I'm very interested in that, and unfortunately there's not good data out there about the waxing and waning of the peripheral neuropathy in L-child.
Right, do you know of any good tools to measure that type of thing that like even a parent could use maybe?
Well then, no, I don't know any of the parents necessarily a parent could use. I'm relying on the docs in our trial, so Dr. Arnold for patients that are here, and Dr. Harding at OHSU. So,
but it sounds like maybe the PTs have some tools that like would give you like numbers, like because I know that the subjective stuff is great, but it's not super helpful in terms of knowing if they're staying the same or progressing or regressing.
Yes, so our testing gives us specific numbers.
Oh, awesome. Not that I love data or anything.
Yeah. I just wasn't sure because I don't know.
So I want to speak to that a little bit. Our experience with Dr. Tucker was Alex was her patient, and this was at the time that Alex was very low and then began to recover. So the having those measures were very helpful, and yet Alex would often, especially on evaluation days, would qualify what this day was feeling like. So there were times that I believe that you would put off an evaluation because it was not a good day or it was not a good week. And so maybe we would plan to do the evaluation next week, or hey, the evaluation is going to be due in the next 4 weeks. So we planned for it for a day, and if we thought we were going to be okay, great. And if we thought we weren't, sometimes we would give her a heads up and we would say, that's right, they would split it up often so that the reads were as accurate as they could be, but also giving Alex those waxing and waning days that were very evident in her everyday life, especially as she was working hard to recover.
It does come down to clinical judgment a lot, and that's one of the things I love about what I do, where as a physical therapist, I get to build a relationship with my patient and their family. I'll be seeing them once, twice, maybe 3 times a week, and really getting to know them, what their movements look like, to see, okay, maybe something's a little off today, maybe we need to change things up, or okay, this is a great day, let's see how far we can go.
I have a question about protein surrounding rhabdo episodes. Whenever I feel like I'm losing all this muscle that's breaking down, and I know protein helps to rebuild the muscle as well as with exercise. So where would protein be best beneficial, and maybe like a goal amount during a recovery week or two after a rhabdo episode that would be beneficial in that process?
That's a great question, Alex. I think of it as a percentage of calories rather than gram amount, so it's different based on how many calories you're eating. And I'm typically shooting for like 15, if we're really pushing it as high as 20, but that's kind of a lot of protein to get in, but 15 to 20% of total calories is probably what I'm looking for. I also think having really high, good quality protein, so the best quality proteins are non-fat dairy and egg whites have really good mix of proteins, so I do think, leaning on those kinds of proteins. Beans and vegetarian proteins are great, but they're a little bit limiting in a few amino acids, so after rhabdo, I'd probably lean on those more complete proteins a little bit.
I don't know if this question is going to be too complex or not, but our daughter is the one with LCHAT, our son is the carrier. However, he has hypotonia, and he's been seen by neurology, and they say he has spastic diplegia, which is not from cerebral palsy, but could be from lipid metabolism. I was wondering if you've seen cases or heard of that runs in families where the carrier is having issues with spasticity and hypotonia, whereas our daughter, is, the full-blown LCHAT, but I just don't know if we should actually get him tested for these other possible lipid type of things.
I don't know how to answer the testing question, but I will say that at least in the field, and the scientists, the symptoms in carriers is hotly debated. So most people would tell you the carriers don't have any symptoms. However, mothers who are carriers for LCHAD, we know, get really sick during pregnancy. So clearly carriers can get sick because it happens a lot during those pregnancies.
Yeah, I definitely did.
Yes, and I would say that probably 80-90% of moms who carry an LCHAD affected infant do get HELLP syndrome during pregnancy. So it's clearly possible. And then I've had other parents tell me, I was training for a marathon and put myself into rhabdo. So can carriers get sick? I think the possibility is certainly out there. Have we ever looked at it? No, not really in any sort of systematic way. So I don't know what to say about that particular case, but I would say that I don't discount the fact that carriers could potentially have some symptoms.
He's had to have physical therapy,
right?
Just to be able to move his lower extremities, where it just is baffling to me.
So I guess that's where I'd say with carriers, it's hotly debated in the scientific world, and no one's come to any sort of conclusion at this point.
Right. I had the same question for lots of reasons, but so I did a little dive into the publications on that. In MELAS, which is another mitochondrial disease, there's good documentation and published reports that yes, the carriers are effective and it's measurable. Also, but not all carriers. So it could be a different genetic background or something else, like some carriers are affected, some aren't. And in CF, in one of the cystic fibrosis, there's a great graph where it shows the activity of the enzymes involved in carriers, and the affected carriers have a similar level of enzyme as homozygotes. So there's a couple diseases where now they've proven that some of the carriers are absolutely affected in the same way by measuring the enzymes. So I don't know if they haven't looked at it in FDODs, I don't think, right?
Not in, I think in mitochondrial disease it's more common because of the
maternal.
Well, no, but yeah, maternal and heteroplasmy. Not all tissues have the same mutation load, so it's a little bit different than a nuclear gene.
But CF.
Right. True. So I guess the question is I don't really know for sure.
Anyone else?
Okay, this is a super simple question, not in comparison to the really difficult one just now. And this may be, I hope you're not gonna say this is like preference or whatever, but sick day routine. I've, in different stages of Canaan's crisis or whatever, been given different information for what to use as like the main liquid, whether it's Gatorade versus Pedialyte versus grape juice even once, and it was like, well, yeah, use that over Pedialyte or over, and this is what we're adding MCT oil and sugar to. What's the difference? Like, is there, like, Gatorade's my go-to, but when I got this grape juice thing, I was like, oh wait, grape juice? Why? What's the new thing with grape, right? So is there any difference in these different liquids that's, you know, more beneficial, different, like if you're really far gone, we'll do one over another. Like, what, is there anything that you guys know?
The biggest difference, at least off the top of my head, from Gatorade to grape juice is the electrolytes in Gatorade. The sugars might be slightly different. I look at Marie if I know what the sugar is in grape juice versus, I think Gatorade's mostly dextrose. I don't know. I think it's pretty subtle differences, Sharika.
So, I'm Georgianne Arnold from University of Pittsburgh. I work with Dr. Bockley. Gatorade has about 7 calories an ounce, but it's glucose, so you can use it pretty quickly. Soft drinks have about 12 calories an ounce.
But it's mixed and fructose.
Pardon me?
But it's sucrose.
Yeah, but it's sucrose. And grape juice, some grape juices actually have quite a lot of concentrated sugar in them. So if you read the label, how much sugar is in it, and but Pedialyte has very little sugar in it. If you're going to use Pedialyte, you need to mix it with something. Pedialyte grape juice might work. So when you give somebody with diarrhea a high sugar concentration, you can make the diarrhea worse. So I probably would not use grape juice in somebody with diarrhea. But if they're just having a day where they're just not hungry and you want to get some sugar in them, yeah, that works.
So, Georgianne, is the grape juice glucose, or is it, because apple juice, for instance, has a really high concentration of fructose, and I wouldn't necessarily go there.
I don't know what the sugar
You don't know what the sugar is in grape
juice.
juice. I'll look it up in our metabolic pro system and let you know.
We appreciate it. I have a question for either this woman or Mrs. Dr. Gillingham. They were talking about Gatorade or Pedialyte. What about Propel? Is that ever considered?
So Propel is a great supplement, but doesn't have carbs. It's or you're talking about MCT Propel?
Just Propel.
Propel. Gotcha. I think that the concentration in the sugar for Propel is as high as any of the others that we're talking about.
Okay, thank you.
Anyone else? Second?
So I'm just curious if you guys can kind of explain what happens when your child eats too much fat, and where does the fat go, and do you or what is your hypotheses about that? And then if there is a day with too much fat, I don't know how it all works out. After listening to the lovely liver talk too, I thought it kind of fit in.
I didn't hear the question. So the question is, what happens to the fat if your body can't break down the fat? Where does it go? And kind of what happens?
Well, who wants to start?
I'm just guessing that it would get temporarily stored in the liver. It might go through eventually through some alternative pathways. There's another organelle called the peroxisome, which can break down fat to a certain extent, and it might end up eventually resolving. But if it's something chronic, if you're chronically consuming too much fat, I would guess it would get stored in the liver.
So I think the big answer is we don't know for sure. We did a study to look at lipid storage in the liver and in the muscle in patients with LCHAD compared to normal healthy controls. And when they're well, their liver fat was not different than the normal healthy controls. So it doesn't seem to accumulate when they're well. We know when they get sick that they get lots of fatty liver, they can get lots of fat in the liver. As far as LCHAD females having a baby, I'm aware of, I think, 3 pregnancies that have happened. That's the only 3 that I'm aware of, and those pregnancies went well. Subsequently, after pregnancies, the moms have struggled, but during the pregnancy they did okay. So, but that's 2 to 3 cases max, and those are anecdotal reports, and so we don't have a lot of information. Given that we just, described these disorders in the 90s, we're kind of waiting for those girls to grow up to be mothers. So I think it's a bit of a watch and wait right now.
I've heard anecdotal reports of CPT2 patients doing well during pregnancy as well, but it's anecdotal.
Yeah, and I've had several CPT2 patients who've had several children and have done very well in pregnancy that actually have felt better during pregnancy. So that's true.
Do you mind speaking to anything that you can tell us about the study that you're doing in Oregon for the eyes? I know it's not done yet.
Mom,
Yeah, I can tell you what we're doing. So we did finish our recruitment. So we enrolled 40 patients across the lifespan from 2 on up, and I downloaded and we did the first cut of the data yesterday. So I don't have the results yet, but we're looking at describing specifically mutations, how certain mutations are related to vision loss over age. We're looking at the effects of newborn screening versus being presenting symptomatically and how that affects vision over time. We're looking at, there's 2 cells in the eye, photoreceptors called rods and cones. Is it rods or cones that are more affected over time with age? So my statistician is running those results right now, and we'll present the first data for that at the Inform meeting in Freiburg. And so we're working on those kinds of analyses now. I still have, I need to send blood samples off for analysis to try to correlate that with biomarkers in blood, which we haven't done yet. But then all the patients will come back in 2 years and we'll repeat it and see how it changes over time. So that's what we're currently doing. I don't have any results at the moment, but I did send the data to the statistician yesterday. So we're starting to look at the results.
Okay, just curious because I know there's several of us who have kids or are doing. My son's due back.
Pretty soon.
Yes, pretty soon. So I just wanted to see what you could share with us, but I'll wait till you get to Germany.
Okay, we're working on it as fast as we can.
Dr. Arnold, thank you for jumping in and joining the panel. I just wanted to see if there were any updates or anything exciting that you have going on that you'd like to share, or maybe you can't share. But I just wanted to give you that opportunity if there was anything you've been working on in research or anything that you might be able to share with us.
Well, I'm on hospital service right now, so I missed Dr. Vaca's talk this morning, so I don't want to repeat anything he talked about. But we have 2 studies in the very early stage for MCAD. One is giving C7 because it turns out that the SCAD enzyme will metabolize C7, not the medium chain enzyme. And the other, I actually thought we would have data by now, but getting the IND has taken a lot longer than we thought to get that going. And the other one is giving a urea cycle drug called phenylbutyrate to people with MCAD because it turns out it might be a chaperone. That is, it might take an MCAD enzyme that's misshapen and help hold it into the correct shape. So we're going to be asking for people with MCAD to come and be part of our studies very soon.
That's wonderful. Thank you. That's exciting to hear more about the MCAD community.
Hi, I'm Beth, and our son Luke is 16. He was involved in that eye study here last year, the first round. Since then, he's been to his new ophthalmologist down at the Shea Institute in Philadelphia, and he noticed some mild progression and has prescribed lutein, 6 milligrams. Have you seen any, do you have any data on lutein and RP?
So A couple of things. So lutein is part of the ARAD's mix of vitamins that have been studied most in macular degeneration. And I was on a panel for the Veterans Association, actually, where we looked at the data to see, does it help? And in macular degeneration, it does slow progression. We have absolutely no data that the same is true in LCHAD. Do I think lutein is harmful? No, but do I think it's going to stop LCHAD retinopathy progression? I don't know that we have any evidence, because the disease processes between macular degeneration and LCHAD retinopathy are very different. So I think, it's not going to, it's a supplement that's pretty, pretty minor, and so I certainly don't think it's going to hurt at all, but I'm not sure that that's what's going to slow the progression. As far as retinopathy, the good diet control and trying to stay as healthy as possible is the best thing we have. We haven't found something that can stop it. So that's one of the reasons why we're doing the natural history study, is to really find out how we can stop that progression.
Any other questions? No? So in the last few minutes, Dr. Gillingham, can you share with us, you're going to be speaking with MitoAction in September, October, about some studies that you have. Do you want to share a little bit about that and those presentations?
So yes, Stephanie's asked me to present some data that I did recently in Surge. So I think the first one we're going to do, if I'm correct, is on a chart review that I've been working on for cardiac, the cardiac symptoms in older adults and young adults. So we'll be talking about that. It's a retrospective chart review, so it's not an actual intervention study. So it's really kind of trying to describe, as kids are getting older, what we're seeing with hearts. So that'll be the first talk that I'm going to do. And then the second one is going to be on retinopathy, and I'll describe sort of the differences in LCHAD retinopathy, pathophysiology, what we know, what we don't know. And then I'll talk a little bit about some of our basic science work. So my lab, we created an LCHAD mouse, and the mouse does get retinopathy. So their eyes do get some of the same phenotypes that we see in the patients. And so we're working on a treatment, and I have a graduate student we're about 4 months away from doing a retinal gene therapy in the mouse to see if we can rescue the mouse's vision. So we're moving towards novel treatments and trying it in mice first. So
that's exciting. Well, we look forward to sharing more of that information with the community. Any last words or comments from any of our panelists before we end for the day, or any last questions?
This is for her. Do you have any advice for consuming only medium chain fat and repairing the damage done by sugar to the liver? And her daughter has LCHAD.
I didn't hear that, I'm sorry.
I'm sorry. Do you have any advice for consuming only medium chain fat and repairing the damage done by sugar to the liver in an LCHAD patient?
I'm sorry, I still didn't hear. I have hearing loss, but I'm not wearing my hearing aids because the mask pulls them off. So can you put that right up in your face and try it again?
Okay. Do you have any advice for, sorry, can I say that again? Consuming only medium chain fat and repairing the damage done by sugar to the liver.
In patients with LCHAD?
Yes, and this is a translation, so I'm not sure if it's coming across correctly.
Well, you need some long-chain fats because there are some essential fatty acids. So I think to try to find a diet that had no fat in it would actually not be good for, no long-chain fat in it would actually not be good for you. What do you think, Melanie?
So, yes, I think a little long chain fat, and I don't think of the sugar necessarily as being as damaging to the liver. So we need the sugar, probably. So sugar and MCT being good for the liver.
I don't know what you would eat if you didn't eat sugar and you didn't eat long chain fat.
Okay, thank you to our panelists. We appreciate you giving your time and answering these questions. Not often do patients get this up close and personal with the leading experts in their rare disease. So we really appreciate you taking the time to be here with us this weekend and to answer questions. and share your expertise. You're fabulous, and we're grateful for you. So thank you.